now invite the last speaker of this session, Dr. Amrish Agarwal, who is currently a senior consultant cardiologist at the Fujairah Hospital, and he also happens to be the assistant professor of medicine at the Ras Al Khaimah University of Health Sciences in United Arab Emirates. This morning, Dr. Agarwal joins us to deliberate for the next 12 minutes on low flow, low gradient aortic stenosis with left ventricular dysfunction, when and how to intervene.
And at the onset, I would like to thank Dr. Chopra, Dr. Nanda, and Dr. Pareshar to ask me to come to share my thoughts in this really actually very important topic with you. As you all know, we are all getting older, and as we become older, there is a lot of focus on coronary artery disease. But one unattended area is that as we become older, our joints and our cardiac walls are going to become calcified and thickened. So more and more people are going to suffer from aortic stenosis, and this area is going to focus on that. We all know that the data derived from echocardiography plays a critical role in the hemodynamic grading of aortic stenosis. We know that we can calculate the peak gradient, we can calculate the mean gradient, but this data actually are flow dependent. We can also calculate the area across the aortic wall, and this being a little bit flow independent is a better measure theoretically. But the current American guidelines require a peak gradient of nearly more than 4 meters per second and a mean gradient of 40 millimeters of mercury and a valve area of less than 1 centimeter square to diagnose severe aortic stenosis. But these values are dependent on normal flow and normal left ventricular function. The gradient across the wall is actually dependent on transvalvular aortic flow rate, and hence it is not surprising that in the presence of LV dysfunction, this gradient across the wall can be first low. And two is not, and the fact remains that nearly 10% of population can have this kind of situation. That means of all the aortic stenosis we see, up to 10% can fall in the subset of low gradient, low flow aortic stenosis. Let us take this example on a 72 years old male and who has gotten aortic stenosis. As you can all see, the left ventricle is thickened, is hypertrophic and diffusely hypoconductile, and the calculated aortic valve area is little bit on the lower side, but the ejection fraction, when we calculate by the Simpson's method, is 36%. That the peak gradient across the aortic wall was 49 millimeters of mercury, and the mean gradient was 30 millimeters of mercury. And when we calculate the aortic wall area, we are not surprised to find that the area is on the lower side, 0.8 centimeters square, indicating to us that there is a strong possibility that this stenosis may indeed be tight. We also looked at the longitudinal function of the left ventricle by using speckle-based echocardiography, and you can see that the whole left ventricle is actually decreased in the function longitudinally, and the global longitudinal function is only minus 6.8%, indicating severe left ventricular dysfunction. This entity of low flow, low gradient, severe aortic stenosis with LV dysfunction is being defined as severe stenosis as defined by area less than 1 centimeter square, a low mean gradient across the aortic wall, which by value means less than 40 millimeters of mercury, in the presence of significant LV dysfunction, which means less than 40%, and these Americans and the European guidelines, they nearly coincide in this respect for him. When we face such a patient, the clinical challenge remains that if we subject this patient to medical treatment, they have a very, very poor prognosis, and in fact, nearly 85% of these people are expected to die in nearly 4 years' time. On the other hand, if we subject them to surgical therapy with aortic valve replacement, they carry a very high perioperative and the intraoperative risk. And so the clinical challenge remains in handling this type of patients. We have to actually define our mind what type of LV dysfunction we are dealing with. It is possible this can be true severe aortic stenosis, where the LV dysfunction is the primary pathology and it is occurring because of afterload mismatch, because of severe aortic wall stenosis, and the LV dysfunction is occurring secondary due to severe stenosis. It is also possible that this can be a pseudo-severe aortic stenosis in which the aortic wall is actually moderately stenosed, it's not severely stenosed, and the LV dysfunction is occurring because of any other pathology, and so that is why we have a situation in which the area of the wall is low, because the wall is actually not opening fully, because the left ventricle is not generating enough pump pressure to push the gradient across the wall for him. So we really have to separate the sheep from the wolf. A clinician has to distinguish between a true stenosis and the pseudo-stenosis. At the same time, a clinician has to decide which are the patients which are going to benefit from operative treatment so as not to have a very high surgical mortality on their hands for him. For this, we have to use actually a low-dose dobutamine, and the use of low-dose dobutamine is to stimulate the heart to have more increased contractility. When we use a dobutamine in such a fashion, we find that we have a situation in which there is true severe aortic stenosis, in which the low dose dobutamine causes increase the stroke volume, and this increase the stroke volume is able to pump the more pressure across the aortic wall, and because the aortic wall is inherently very stenotic, the area across the aortic wall does not change as much. On the other hand, in the severe aortic stenosis, we find that as the stroke volume goes up, the left ventricle pump is able to open the moderately stenosed aortic wall little more openly, and so hence the aortic wall area increases. So we have a two situation, true severe aortic stenosis and the pseudo-severe aortic stenosis. In true severe aortic stenosis, the area does not change. In pseudo-severe aortic stenosis, the area will change, but the mean gradient will not change. And the last condition, which actually sometimes we say clinical practice, is the absent contractile reserve, in which the left ventricle is so sick that dobutamine fails to stimulate, and hence the stroke volume will not increase, the mean gradient will not increase, and the area will not change. So our patient actually went dobutamine stress echocardiography. And you can see, as we jacked up the dose of dobutamine, the LV contractility increased from 10 microgram to 15 microgram to 20 microgram, and the heart rate went up from 86 to 112 beats per minute, and the blood pressure increased from 112 by 70 to 131 by 73 at the peak dose. So this patient exhibited a good response to dobutamine. We also look at the longitudinal function of the heart by dobutamine, and you can see these two are the basal images. You can see the left ventricular function is actually significantly reduced. There are more pink segments and less red segments, and with dobutamine, you can see that the heart contractility has become much more robust, and there is a more red areas, which indicates an improvement in the longitudinal function with dobutamine for him. Coupled with the increased contractility, we could see that the gradient across the aortic wall is increased. And as you can see, the resting gradient was 49 peak and 30 mean, went up to from 49 to 89 peak gradient, and from 30 millimeters of mercury to 50 millimeters of mercury across the wall. This indicates a significant response with dobutamine, and the aortic wall area remains unchanged. So we have a situation in which the peak gradient increased, the mean gradient increased, and aortic wall area increased, and the stroke volume went up by from 56 ml to 72 ml, and the left ventricular ejection fraction increased from 36% to 44%. So our patient, in summary, has got increase in the stroke volume, increase in the peak gradient, increase in the mean gradient with no change in the aortic wall area. So we can classify this patient as a true severe aortic stenosis with a presence of contractile reserve. And such a response actually characterizes a good response to surgery, as seen in the classical paper by Monin et al. You can see these people who exhibit this type of response, they do very well with wall replacement, with actually a low dose mortality perioperatively and a long-term survival, which is quite significant and better than those patients who are subjected to medical treatment. This type of response to dobutamine allowed the European heart to label as a class 2A indications for aortic wall replacement. That means when we face a patient with a low gradient aortic stenosis and we find a contractile reserve, the European Society labeled this as a class 2 indication for aortic wall replacement. And when there is no contractile reserve, the European Society felt this is a class 2B indication for aortic wall replacement. And 2014, the American guidelines also aligned themselves with the European guidelines, and they said that dobutamine stress echo is reasonable to evaluate patients with low flow, low gradient aortic stenosis with LV dysfunction, and if positive with dobutamine, to consider aortic wall replacement, and they called this as a class 2 indication in their 2014 wall guidelines for him. So our patient, I did an angiography for him, and the angiography showed that his coronary arteries are normal. He actually went, because of his old age and comorbid condition, he underwent transcutaneous aortic wall replacement, and you can see there's a left ventricle and there's an aortic wall, a core aortic wall, which we put in the aortic wall position, and now there is no stenosis. The blood flow is very laminar, and there is actually a small tiny paravalvular leak. And the left ventricular function, because the removal of obstruction, has improved significantly by putting an aortic wall replacement, and this is actually has a very good response if you find a patient like this for him. Let us take another example for a person who has got a dilated left ventricle and LV dysfunction. You can see with us, this left ventricle is dilated and diffusely hypocontractile, and the ejection fraction when we calculate it is only 25% with a stroke volume of 51 ml. The resting echo showed a peak gradient of 46 millimeters of mercury and a mean gradient of 27 millimeters of mercury. So we did a dobutamine stress echo for this person, and you can see with So we did dobutamine stress echo for this person, and we found that with dobutamine, actually the left ventricular contractility has not improved at all. The ejection fraction, which was 25% before, has improved only to 30%, and the stroke volume did not change much. It showed less than 20% increase in the stroke volume with dobutamine, and the area did not change much, and there was actually not much change in the peak gradient and the mean gradient. So this response in our previous classification indicates that there is no contractile reserve. Why no contractile reserve? Because there is less than 20% increase in the stroke volume, and the stenosis severity, actually we cannot determine. It is possible that the stenosis may be severe, but in our study the stenosis severity is undeterminable, and this response can be classified as a pseudo-severe or can be classified as a no contractile reserve, and this patient is unlikely to benefit from surgery. This has been the traditional teaching for so many years, that the absence of LV contractile reserve is a contraindication for valve replacement. And many authors looked, is it really true? Is it true that if you have no contractile reserve and you do an operation, then you will do, the patient will do very badly? And one of the group led from France, they looked at this data, and they looked at 81 persons with low flow, low gradient aortic stenosis with no contractile reserve. They found these people actually had a very high operative mortality. That means because the left ventricle is very poor, they did very, very poorly post-valve replacement. But in spite of doing poorly in the operative mortality, these people actually had a good long-term response. As you can see, that the two curves, they separate quite widely, that this is the people who had an aortic valve replacement, and these are the people who had a medical management. So in spite of having a high operative mortality, they did well. And when you correct for the baseline comorbid condition, the differences persisted. And there are some authors who believe that if you don't have any contractile reserve, you can still subject this patient for an aortic valve replacement. So how do we put these puzzles together? How shall we put all this data, which you had seen over last few slides, put this together? In my opinion, in our laboratory, we assess dobutamine stress echo in all patients in which we find discordant data. If you find an ejection fraction less than 40%, we find a mean gradient less than 40 millimeters of mercury, we subject them to dobutamine stress echo, and we look at the contractile reserve. If the contractile reserve is more than 20%, means if the stroke volume goes up by 20% or the ejection fraction goes up significantly, then in this type of people, we will try to look, are we dealing with too severe aortic stenosis and or pseudo-severe aortic stenosis by looking at the incremental increase in the peak gradient and the mean gradient. If there is a true severe aortic stenosis, we will subject them to surgical AVR or cabbage, or we can subject them to transpercutaneous aortic valve replacement by percutaneous technique. If there is a pseudo-severe aortic stenosis, in that case, the stenosis is not severe, and mainly the increase in the gradient is a lack of the increase is because of the LV dysfunction, and we will put this patient for medical treatment for him. If we find no contractile reserve,
you've just run out of time.
Only 1 minute, please, 30 seconds. We find that these people, we will try to look at the calcium score, and if there is a significant calcification, then there is a strong possibility that these are the people who will benefit from surgical placement for him. So the take-home message is that the low flow aortic stenosis is not uncommon. It is very, very important to determine true severe aortic stenosis. Low dose dobutamine should be used to determine contractile reserve. Surgical AVR is beneficial for most patients, but many of these people are elderly and they have many comorbid conditions, so TAVI is very, very alternative. And our centers in Fujairah and in Sharjah, we tend to use TAVI in these patients a lot for him. Thank you very much for your kind.
Thank you, Dr. Agarwal. Please have your seat. Ladies and gentlemen, we have the next 8 minutes for discussion. We'll have the microphone standing, and it's over to the chairpersons. Thank you.
A single question from all the senior ladies. I am 70 years old. I am taking regularly calcium 1 gram or 1.5 gram. I am taking regularly arogetal injection 6 lakhs unit. Did I get any, future chances to get the calcification of the valve? What precaution I should take from your message that to prevent the calcification of the valves? Are there any chances to get my valves calcified because of the calcium, arogetal, whatever the drugs I am taking? Please guide me. Thank you, sir.
Can I respond? I think year before last year, we published a paper in Indian Heart Journal. And it was a very robust paper because the top university doctors were involved. Almost about 9 or 10 people were involved. And the subject was a role of statin in preventing calcification of the aortic valve and the role of statin over prevention of mitral annular calcification. There is a huge data. Now the question is when to start statin and how to prevent it. When you start statin, when you already calcification is set in, it's too late. If you start statins earlier, at the age of 50, when there is no calcification, I'm sure we can postpone calcification in the aortic valve. The aortic valve calcification and the mitral annular calcification is a free radical injury. So whenever we reduce the oxidative stress, it's going to help. Naveen, if you want to give any comment on this.
I may be wrong, but I think there are certain papers which have said that possibly statins have got not a very significant role in preventive calcification of the aortic valve. There were some initial papers who were did this one, but I think some of the later were doubtful. The role has been a bit doubtful. The role
Statins.
of statins in preventing calcific aortic stenosis. Role of statins in preventing calcific aortic stenosis.
Yeah, I think what we do many times is rather than look at gradients, we just do a 3D echo and look at the valve area directly. I mean, that's the best way to look at it because gradients will depend on the loading condition. So the aortic valve area may not depend that much on the loading condition. Even then, if the stroke volume is very, very low, you'll still have a problem. The problem comes up in patients who have normal LV function and they have low gradient and then still have very severe aortic stenosis. In those patients, we calculate the stroke volume, and the stroke volume is, if it's less than 35 cc's, then we go on the aortic valve area. If the aortic valve area is still narrow, then those patients, despite having a low gradient and despite having normal LV function, those patients would undergo aortic stenosis. And this happens in patients who have severe left ventricular hypertrophy. Basically, it's because they have severe left ventricular hypertrophy, the inflow is restricted, and that's why they have small stroke volume, and that's why they have low gradient. But they have severe aortic stenosis. So that's another separate group of aortic stenosis.
Yeah.
I'd just like to mention one point, the reference to the question you raised. There is a huge data on extra lipid lowering effect of statins. And I'm totally convinced in my mind, don't go by odd recommendation or odd papers of contradiction. Understand the dynamics of working of statins. They are very powerful, having an antioxidative stress mechanism. So statins have a huge role, not only in the aortic valve, even in the vessels. Endothelium integrity is preserved with statins to a very large extent. If you see the data from our own...
Sir, I am taking calcium erythritol for osteoporosis. I don't have any heart problem at present.
Yeah.
But just to prevent the calcification
See,
of the valve.
the message I want to convey you after menopause, with the full chemistry, when there is a data to show the effect, pleiotropic effects, even on osteoporosis of statins. Huge data.
Okay.
Parkinsonism, peripheral vascular disease, renal vascular disease, carotid disease, cerebral vascular disease, everywhere.
Her question is very straight.
Sir, is
should
the-
she take statin to prevent aortic stenosis? That is a specific question.
The
Sir,
question-
is statin
the question-
Sanjeevani?
I think no.
The question,
Statin Sanjeevani hai
Just-
kya?
See, just listen to me, madam, just listen to me. We are giving you logic. The logic is aortic valve or a mitral valve is nothing but projection of endothelium.
Right.
If you want to maintain the integrity of endothelium, the answer is statin is the only answer with lifestyle modification. I can't give you the answer. Does it really prevent aortic stenosis to that extent the way we expect? I don't have any answer. But there is a logistically role of statins. We cannot say no or yes because we are not authorities. We become authority when we work on it. The data is favoring.
Okay.
Create your own protocol and see whether it
Right.
works or not.
I think Catherine Otto, who has done a tremendous amount of work on aortic stenosis, tremendous, I think the maximum, she also recommends that possibly there is no role of steroids, of statins in preventing aortic stenosis or so.
I don't think we believe one statement by one doctor. We want a double-blind, randomized controlled data by many authors to validate. One person can give a viewpoint is not acceptable. It can be rejected on many grounds. It has to be multiple opinions to come to a consensus. That's how there is a controversy and consensus comes quite late.
But we cannot fight against him because
We
he
do
is a
not-
master
the
orator.
reason I tell you is,
But I
don't believe my statement. What I'm saying is, logistically, it makes sense. Create your own protocol, create your own data.
Right.
Don't believe in one individual data.
Right.
Create your data, satisfy yourself. Logistically, it makes sense.
Sir, can I add a small thing? At times, very often, the body is overloaded with calcium by a lot of people. She currently has osteoporosis. Probably you won't have it. But moment you start overloading, you take sufficient milk, your levels are all right. After a prolonged period, probably you have to decrease the level of calcium. Because overloading the body, obviously calcium is going to go somewhere.
May I answer this question? Actually,
Well, first I am grateful to Dr. Chopra and Dr. Parashar for giving me the opportunity to come over here and speak to this audience as a speaker. Now, first I will talk about Dr. Chopra because the problem involves all three, you see, all three speakers. First, when there is no indication in my patient, who is 75 years old, a doctor, senior doctor, consultant, I also came with that patient to Dr. Parasar, the question of doing angiogram in a patient of coronary artery disease, where there is no evidence. So he actually has got no sleep because since then he's thinking whether he will go for coronary or not, angio. So now I've got the answer. Second, about basic life support and advanced cardiac life support. And my question is, when, because I'm involved in this, the question when there is road traffic accident injury involving the face and the chest, what about the basic life support and advanced life support? Third, Dr. said, yes, I wanted to show you this patient, which already discussed it, so we'll take up that later on. Thank you very much.
Can I take the question on? So the question was, what's the role of basic life support in case of trauma? So that three things that I would like to mention. So the talk I gave was purely for sudden cardiac arrest. So if somebody has a trauma, then you need to initiate advanced trauma life support. That's different from advanced cardiac life support. So we're talking about sudden cardiac arrest. Somebody has an MI, and we heard from Dr. Chopra, first presentation of acute MI in most patients, especially young Indian patients, is sudden cardiac arrest. So ATLS, that's a trauma life support. That's totally different. Okay? Now you can apply some of the BLS and ACLS art to the trauma support, but that's a different topic. Now, yeah.
Can this patient
Sorry
have
for the
sudden cardiac arrest? This patient
interruption,
of
Mr.
trauma?
Chairman. We have totally
Yes,
run out of
okay.
time for the discussion on this particular session. Can we move on
So,
to the presentation?
Same thing is for pure respiratory failure. If somebody has pure respiratory failure, yes, you need to intubate them early. You need to call Dr. Murthy, intubate them early. Chest compression won't work. This is for pure sudden cardiac arrest. And in interest of time, I think Dr. Murthy has some comments, so I'll actually let him talk here.
Thank you.
yes.
I do really appreciate giving me this opportunity, and I thank all the members for giving update. Congratulations. I'm talking from the message that was given by Dr. Sharma. The message is very clear. Quality, basic life support given within the first 2 to 3 minutes. The golden minutes after cardiac arrest, followed by therapeutic hypothermia of 32 to 34 degrees centigrade is the only accepted modality in the world today. I'm talking from the not only from my experience, from the experience of the resuscitation scientists. 5 years from now, I would like to see each and every institution in India to participate in this major project of hypothermia in cardiac arrest. I also appeal to all of you to read this great article which was given in the Critical Care Medicine 2009 by Pollerman et al. That's a great article which will give you a lot of information about reversing the unleashed metabolic activities resulting in mitochondrial destruction. We are not talking about life and death now. We are talking about between life and death, there is a very narrow lane, and that is called the mitochondrial resuscitation. The scientists of the resuscitation science, they're looking into it, and this is not experimental anymore. This has been there, and it has been proven beyond doubt. I passionately appeal to all of you to look into this project of the hypothermia after cardiac arrest. Our experience, initially we used to do this modality for only ventricular tachycardia and ventricular fibrillation. And we also found out that asystole in selected cases is also an indication for resuscitation. And there is a long-term follow-up. The Resuscitation Science Symposium, which is held by the American Heart Association for 2 days every year, attended by 15,000 resuscitation scientists across the world, will give you a lot of information. The latest information that you can get from us, from the viewpoint of the resuscitation, is from David Hillgrant from Indianapolis. He has shown beyond doubt the long-term effect of the cerebral protection in the category 1 and category 2 of the cerebral performance category in selected cases of hypothermia. So please do consider. You will be telling me 10 years down the line that all of you will be doing it, but I would rather have you do it earlier than later. Thank you.
I'm sorry for the interruption, Mr. Chairman. We have totally run out of time for the discussion on this session. We'll move on with the presentation ceremony. May I firstly invite Colonel Parashar to please step forward and present a memento to Dr. R.N. Seth. Dr. Seth, if you could kindly step forward and accept the presentation. May I invite Dr. Seth to please step forward and kindly accept a memento from Colonel Parashar. I would now like to invite Professor Anita Saxena to kindly step forward and present a memento to Dr. Amit Sharma. Dr. Sharma, if you could kindly step forward and accept a presentation from Professor Saxena. May I invite Dr. Vimuri Murthy to kindly step forward and present a memento to Dr. Chopra, who will receive it on behalf of Dr. Mark Monin, whose lecture he had delivered. And I'd like to invite Professor Navin Nanda to kindly step forward, and he'll be presenting a memento to Dr. Amrish Agarwal. Professor Nanda, if you could kindly step forward and present a memento to Dr. Agarwal. Dr. Agarwal.